Okay, ladies and gentlemen, it's a great honor and pleasure for me to conclude this lunch symposium with interventional radiology, where to go with fusion and navigation. So even though we have now access to new guidance modalities such as CT, CBCT, MRI, or even PET-CT guidance, ultrasound is still used for the majority of image-guided procedures. And like everything in life, ultrasound is evolving. And today, Toshiba comes with the Aplio 500, which offers new applications and new softwares that might help the radiologist during percutaneous interventions. So what are these tools? First of all, fusion imaging. I think you all experienced the situation where you could clearly see a lesion on MR or CT, and the day of the biopsy, you could not see it with ultrasound. And the technique to overcome this problem was this. You had to look at the ultrasound, look at the CT, concentrate, and then try to do mental fusion. But this was the result, and I think you will all agree to say it looks like the radiologist has been drinking 4 big Austrian beers than real fusion. There's a way to overcome the problem today. It's called smart fusion, and we have seen an example in the talk before. The machine will automatically synchronize the CT or MR DICOM images from a prior examination to the live ultrasound images. And this is how it looks like during an intervention. You can see that we have covered everything in a sterile way. And this was an adrenal biopsy. You can see here the CT images, which are perfectly synchronized to ultrasound images, even though I'm not puncturing in a straight axial plane. So very useful tool. I will give you some example a little bit later on. Second tool, needle tracking. Again, you probably remember all the situation where you were really wondering exactly where the needle was or is. Again, there's a way to overcome the problem. It's to try to move a little bit the needle and try to see something, but it's not always working. Same thing today, we have an easier solution which is called smart navigation, where you just have to fix a small sensor to the proximal part of the needle. Here you go. And then the machine can display you the exact position of the needle on the screen. So it's useful for the approach. This is an example on a liver biopsy mass. You can see exactly the position of your needle. Once you are in the liver, you don't need anymore. But it's also useful for biopsy if you are using a coaxial system. One of the problems when you remove the stylet from the guiding cannula before you insert the semi-automatic needle is that you cannot see the needle anymore. And this is an example in a subpleural lung lesion. You can see here, the smart navigation shows me where's the tip. If I remove it, I cannot see the tip anymore. So it's very useful for some puncture to know exactly from which point you are about to biopsy the lesion. Now, other potential very useful tool, to my point of view, the microconvex probe is very convenient for interventional radiology because it allows you to access lesion even through the acoustic window is very small. This is a typical example of a renal mass, which is referred for radiofrequency ablation. If you are using CT scan, you would target it going directly in between the ribs. Now, if you want to use ultrasound, with a large standard probe, you see that you will be in trouble because you will have the rib and your access will not be perfect. If you are using the microconvex probe, you can have a nice acoustic window to the lesion and perform an approach which is similar to the one you would have done with CT scan. And finally, contrast ultrasound. It has been reported for more than 10 years that it can be very useful to improve the accuracy and the precision of percutaneous biopsies. Now the question you must ask to me is, okay, these are a really interesting tool, but is it really useful in your daily practice? Probably you all remember this advertising for a Swiss chocobar, where the guy had 8 seconds to convince you it was dynamite. Well, I have now a little bit less than 10 minutes to try to convince you that the Aplio 500 is also dynamite for interventions. And this was not without any cheating. So why is it dynamite? Because when you combine everything together, you clearly get something, to my point of view, which is more than just ultrasound. Let me explain. Of course, the majority of the procedure can still be performed using ultrasound guidance alone. However, you will improve your confidence and the quality of the intervention in some complex cases, and you will even be able to perform procedures which are impossible to do with ultrasound alone. And to try to convince you, I will give you some more clinical cases. Let's start with liver, which is probably the most frequently targeted organ with ultrasound. First example, interest of fusion imaging. Look at this small subcapsular hypervascular metastasis, clearly visible on the arterial face of the CT scan, but poorly visible on ultrasound alone. So again, you can go for fusion imaging, and you can see that you can focus your examination on the region of interest and identify this tumor, which was not visible on the first examination using ultrasound alone. Once you have seen the tumor, it's easy to puncture it and to ablate it. Another example, more tricky case, lesion in segment 1, clearly visible on PET-CT and on MR, but not visible at all on ultrasound. So here again, why not using fusion imaging? Look at it. Nice fusion imaging. You can see the branch for segment 3 on both images, and then you use fusion image guidance to puncture the tumor. You can see the needle here, which is targeting the node, so I can see it on the fusion, whereas I cannot really see it on ultrasound alone. And once I'm in position, I can do contrast ultrasound examination to really prove that I'm inside. You will see it, so contrast ultrasound will show the lesion here, and you can see the tip of the needle lying within the mass, so clearly my biopsy is correctly targeted. And in this case, you change something, I would say not impossible, but biopsy that can be tricky to something which is really feasible. A final example in the liver, ablation. In this case, why did we use fusion and needle tracking? First of all, fusion to clearly be sure that this is the tumor we have to treat. And why needle tracking? Because we are going to access the lesion with an out-of-the-plane approach, meaning the microwave antenna is positioned through an intercostal approach, whereas the ultrasound probe is positioned with a subcostal view. And in this case, the needle tracking software helps to show you and to display exactly the position of the tip of the needle, and then you can correctly approach the tumor and be really in the good axis to access that. And once you have done the microwave ablation and you want to cauterize the tract, you will overcome the problem of gas formation. Look at this. You have so much gas that you don't see where the tip of the microwave antenna is, and then activating the needle tracking software, you can see that the tip is here, and you can know what's the length of the cauterization you have to do. So clearly, very convenient tools for liver. Let's move on to kidney, and I will give you a negative example. That's a typical patient from the place I live, 100 kilograms. He drinks too much extra large Austrian beers. And we are supposed to puncture. I was in a hurry, so I did not want to use fusion and needle tracking. I say, I do not have 2 minutes. I want to go straight with ultrasound. So this is how it looks like. The mass is here. You can imagine that my needle is here. However, once I was in the lesion, I was wondering really where the exact position of my semi-automatic needle was. So hopefully I was in the CT room, and we did a 3D acquisition that shows that we were in good position. However, I would have loved to see that. So if I took 5 minutes more to do fusion and needle tracking, this is the kind of images you can have, and so you are much more confident for your procedures. Now moving on to thorax interventions. You know that you can target subpleural lung lesion using ultrasound. However, it can be challenging. First of all, because you have the ribs, and secondly, because the pleural contact might be small, like in this case. So here again, microconvex probe, very useful to get an access and to get an ultrasound view to the lesion. However, at that point, I'm a little bit worried. I probably think that the tumor is here, but I would like to be sure. So then you can go for fusion imaging, and look how nicely it shows you that what you are about to target is really the lesion that you have to puncture. And finally, needle tracking helps me to see that I'm correctly targeted in the lesion. And you can see we have a little bit of misregistration between the CT scan here and the ultrasound there because the patient moved a little bit. However, I have all the information I need. I see the lesion, I can see the tip of my needle, and I know that the biopsy will be performed from this point to here, so I will be correctly targeted. Another issue with lung lesion is sometimes the large necrotic mass, which can be negative when you puncture it. That's an example here of a large necrotic mass, positive on PET on the periphery. You see a small acoustic window. So again, use the microconvex probe to go through this window. And here I use the needle tracking. Why? Because my needle is almost parallel to the ultrasound beam, meaning I will not be able really to see it. Once you have done that, if you want to prove that you are about to target something viable, just use contrast ultrasound. And you can see here, I know that my biopsy will be performed from this point, so clearly it will be correctly targeted and the biopsy should be positive. Whereas on ultrasound alone, it's much more difficult to assess that your biopsy will be correctly located. And finally, an example of mediastinum biopsy. So typically, the kind of lesion you would use probably CT guidance to access that. Well, if you use the microconvex probe, probably you can get an acoustic window to access the lesion. This is how it looks like on ultrasound alone. So you have the pulmonary artery there, and you see something here which might be the mass. You see some calcification. Okay. Again, I want to be sure before I puncture it, so performing a fusion imaging. Again, you can see the mass here. You can see perfect registration with the cystic component of the mass here, and a nice registration looking at the aorta there. So now if you want to puncture it, there is still a problem. Is when you will be in the deeper part of the lesion, you will have shadowing of the ultrasound beam due to the sternum. And here we go with the short video. So I will advance the needle using fusion and navigation modalities. I'm pretty sure that everything is well synchronized if you look at the pulmonary artery. And then you can do a biopsy, which would have been very tricky or even impossible using ultrasound alone. So if you see and you combine all these software and facilities offered by this new machine, you can say to your colleagues that, yes, you can do such a biopsy. Now, some of them might still think that this is not really dynamite, so I will give you some bone example, but not bone with disruption of the cortex, bone which is intact. So first example, a patient which is referred for a biopsy of the greater trochanter to rule out any infection here. Okay. So we have to use an anterior approach. Again, this is ultrasound alone. So you know where you are, so you might think this is the femoral neck and you might be correctly targeted. However, again, you can easily do a fusion imaging which was performed on the pubic symphysis. And here we go. Nice registration, and so you clearly identify your target point, which is here. That's not so obvious on ultrasound alone. Once you have done that, activate your needle tracking. You come to the cortex, and once you're here, you need the needle tracking because you will not be able to see the bone trocar once it lies within the bone. So you slowly advance the bone trocar through the lesion, and you should be correctly targeted. So this was one of the first cases I have done, and the patient was on the CT table. So we did a CT to confirm we were in good position, and you can see nice correlation between what the ultrasound shows me and the CT scan shows me. Now you might think, what's the interest to puncture a patient if he's lying on the CT table and to use ultrasound? So I will show you an example of bone puncture where we use only ultrasound. So this is an example of a femoral lesion. You can see that you still have a small part of the bone around, so I might not see the lesion with ultrasound alone. So this is how it goes, ultrasound alone, performing the fusion imaging again on the pubic symphysis, and I know that the target point should be here. I don't see the lesion with ultrasound alone. Local anesthetic of the periosteum. You can see the electromagnetic sensor. Now I'm fixing the sensor for the needle tracking firmly in order not it to move, and then you just calibrate the length of the needle. Once you have done that, I will use again the needle tracking to approach the lesion. So clearly I can nicely show my needle, and once I'm close to the mass, I open it. I'm just connecting it to have the bone sample, and then I will advance using fusion and needle tracking guidance. Look at it. So I'm using both images to be sure I'm correctly targeted. And once you remove this, you will get a bone sample which was positive for metastasis. So if we sum up this case, this is ultrasound alone. I think you will all agree to say that it's not possible to do the biopsy. If you use fusion, you can identify the region that you have to target. However, difficult to know exactly the depth of your needle. And if you use ultrasound, fusion, and needle tracking, you can correctly target this lesion. And if this is not dynamite, I don't know what it is. So as a conclusion, I think these tools are really great improvement for ultrasound-guided procedures. It's easy and fast to perform, 5 minutes on average. You can clearly improve your confidence for complex cases. For some cases, you can perform intervention that wouldn't have been possible with ultrasound alone. And of course, you have to know your limits. I'm not saying that you can do such a procedure with ultrasound guidance. Of course, we will still continue to use CT guidance for such a cryoablation. However, if you perform more procedure using ultrasound guidance, your CT room will be available for other procedures which could be more complex. Thank you very much, and I would like to thank Toshiba for inviting me and also for the great collaboration I have with them. Thank you.